Mental health is not a destination, but a process. It's about how you drive and not where you're going, as mindfully said by Noam Spencer. I, Mansi Dua,
And I, Anjali.
welcome you to the session on digital mental health. Today, we are living in a digitalized world with advanced technology transforming our healthcare, and yet, mental health issues have been on the rise and reaching epidemic proportions. Use of digital technology in the form of online chat platforms, telehelpline numbers, and various mental health applications are now being increasingly used to make mental health services easily available and accessible to the masses. Dear guests, with our special interest in healthcare technology and mental wellness, we're delighted to invite our speaker, Dr. Suresh Bada, sir, Director of Digital Psychiatry, NIMHANS, Bangalore.
Sir is the head of Digital Academy, Forensic Psychiatry and Telemedicine Center at National Institute of Mental Health and Neurosciences, Bangalore. He has played an instrumental role in drafting the Mental Healthcare Act 2017 rules for the Health Ministry of India. With his keen interest in research, he has been an investigator for various research projects, evident from over 360 national and international journal publications. We are privileged to have you with us today, sir. Now we request you to share your insights.
Okay, these are the headings which I'm going to discuss about digital mental health and understand what are the challenges, what are the benefits, and certain important landmark things which has happened in India. Of course, there are many things which has occurred in the private sector. I'll be touching upon them. At the same time, I'll also be presenting about the important which is telemanas, e-manas, and the requirement of disruptive thinking at this point of time. So digital mental health is basically taking mental health to the doorstep in simple words. Okay, it can be e-health, it can be through mobile phone, or it may be even using internet to provide services. So that's basically the definition of digital mental health, or even if you can call it as a e-health. So basically, information technology. The only problem is, between the doctor and patients, there are too many people are coming in between. It may be internet service provider, or it may be the hardware. At the doctor's end, even at the patient end, there are people involved. So that means the information is passing. There are many people involved. So how to regulate these people? It's only not to regulate the doctor. We need to regulate the people in between. Not only that, now the patient has complete freedom that he can record your conversation. If you are giving consultation to him, he can record that. So now the question is, how the digital mental health has been visioned across the world. Because it's information technology is there since many decades. The first and the foremost is access to mental health care. That is the biggest challenge, not only in India, even across the world. Now the question is, like in Bangalore, what happens is, the patients in Bangalore do not come to NIMHANS. The people from other state comes there. What happens to Bangalore patient? They will go to the other state. Why? Stigma. They don't want to go to the nearest hospital where they will be recognized. So with advance of this digital mental health or telemedicine, they can sit in their room and consult the doctor or the psychologist required. So privacy is a big challenge now. So the privacy is at the same time benefit, at the same time it can leak the information. And it decreases the cost of travel, not only the patient, along with the patient, somebody has to go with him. It's not just the consultation. He has to travel from long distance and come here and take consultation along with the family member. So the cost will reduce. And the important is redistribution of the resources, because most of the doctors are in the urban area. Now the question is, sir, whether this telemedicine or the digital mental health, will it change the pattern of health? Will it improve? Let me put it very clear. Technology is not answer for our sufferings. Only it will redistribute the available resources, one. Second one, the quality of services improves. because the lot of time is spent in providing services. Access to care improves. Fourth, the nature of the services also will change. Simple example I would like you to think. Around 30 years back or 20 years back, if you thought about banking sector, every time you have to go to the bank after salary, first you will find majority of the employees are near the banks who are in, at least at the age of 45, 50, they'll remember, sir, aaj salary hai. Nobody you will be finding there in the wards, they will be in the bank, salary collector. Nobody thinks about that now. So there is a change. There is a network which is completely secured. The same thing is going to happen in the healthcare sector. So now the question is, did the employees were removed from the banking sector? No, but the nature of job has changed. Similarly, there was a challenge in banking sector. Sir, these are the people who are old. They don't know how to use computer technology. They have to be trained. The new people came in. The job nature changed. In the health sector also will happen the same thing. It's not going to take away the job. It is not going to take away the doctor or the patient's relationship. It is the way the patient is going to relate with the health sector changes. Sir, I am a surgeon. Without touching the patient, I am not going to do any surgery. Let me tell you, if the surgeon is going to do 10 consultation, out of that, 4 will be or 5 will be in person, remaining 5 will be follow-ups. So where this digital will work is, yes, it will work is before he comes to the hospital, these are the investigation to be done. Do it and come on that day. All questions are answered. Second, okay, now the surgery is done. Follow-up ke liye, once you can come, remaining follow-ups every 3 months, 6 months will occur on telemedicine. Even that means it is the combination which is going to help. It's not just only telemedicine, only in-person consultation is not going to work. The person who is going to buy a car will ask, sir, car to le liya, what is the after-sales customer support? Now the patient will ask, sir, aaj aapko aake milenge, will you be available on telemedicine? I am going to, from Pune, I'll be posted next day, maybe somewhere in Nagpur. I want telemedicine. So if you are offering, they are going to be with you. Otherwise, they will leave you. That means it is the combination it works. That is hybrid model. So what is going to happen with AI and GPT? These are the things which will come in as a mediator, if you ask me. What does it mean? Suppose if I want to do a surgery, the patient will be given these GPT tools, which will talk to the patient, and the informed consent will be taken, and the doctor will come and say, okay, you have seen this video, the information, latest information is available to you. Do you have any questions? That means there will be a digital tool which will give you all the information. There is a trust deficit between the doctor and the public now. That will be fulfilled by the digital part. What does it mean? Suppose if I want to do surgery, this is the public perception. Sorry for the doctors or the surgeons. They say unnecessary surgery karte hain. Now, after you give the information, the digital tool will tell you, yes, you need to do operation or not, what are the side effects, what are the benefits, what surgery is best. The technology will give you the information. Of course, it comes with a cost, but all the information will be given. So that is what we are going to see in next 2 to 3 decades. That means what is our role? Our role have to become a teachers for the AI. What information to be given to the AI machine, ML, machine learning, what are the information we have to provide. If you are giving a good information, you are going to get the same good answer, and we are going to give a good care. So that's where the digital mental health plays, and the transparency will become the important factor, because many a time the patient will say, sir, inside the 4 walls of the operating theater, kya hota hai, pata nahi hai. So now Korea has come up with a legislation, you have to have a CCTV in the OT, because there were sham surgeries for insurance. That means surgeries are not done, patient goes inside the OT and comes out, surgery is done. Insurance is claimed. It is in Korea. So for that, they have started with CCTV camera. Next one is training and mentoring. The sir has, in the previous session, they have told that even how we are going to interact with our students will change. With this, you can see number of mobile applications which are increasing in every year. Every quarterly I'm talking about. This is, if you look at this, every 3 months, how the graph is there. It is between 2015 to 2022, number of application on Google platform, that is Google Play Store. The apps which we talk about are increasing in number. Now let's define the problem in mental health. Sir, we are talking why हमारे घर में तो कोई mentally ill नहीं है, हमारे college में नहीं है, हमारे school में नहीं है, हमारी पड़ोस में नहीं है. So what is that? We are talking about National Mental Health Survey which was done in 2014 and 16. That is before COVID I'm talking about. This was done by NIMHANS, National Institute of Mental Health and Neuroscience, in collaboration with Ministry of Health and Family Welfare. It was one of the largest survey in the country at the same time across the world. What did this survey tell? It talked about we have 140 crore population. At least 10% of them have diagnosable mental disorder. And 1% of them are severely ill who require medication maybe lifetime. What are the numbers? 0.8 crore. 0.8% means 1 crore population. Sir, where are those? They are there, but no family wants to talk about, yes, my son is mentally ill, or my brother is mentally ill. Nobody wants to discuss that. It's a family secret. And they don't want to come and meet the psychiatrist or the psychologist in, like they say, oh, this surgeon is excellent. I got my operation done. Nobody will come and say, oh, yes, psychiatrist badhiya hai. I got my ECT from him. Nobody will tell you. Nobody will canvass you for that. That means we have a hidden epidemic. This is before COVID, I'm telling you. Not after COVID. Now the question is, how many are on treatment? 70 to 80% are not on treatment. So that means the stigma and discrimination, we do not want to acknowledge that we have illness, we want to take treatment. This is the number who are not on treatment. That is called as treatment gap. Now coming to substance abuse, drug abuse. This is again done in 2020. It was again done by All India Institute of Medical Science, AIMS, Delhi. What does the magnitude of substance use we are talking about? This is the number I'm talking about, addiction, not the use. It is alcohol. 2.9 crore people who are addicted to alcohol. That means dependent. It is not just 2.9 crore, it is 2.9 crore families. Imagine one of your family member is having alcohol daily basis. So that is the number, 2.9 crore families are suffering. Talking about cannabis, the numbers, 25 lakh are dependent, that means addicted. Look at the other drug abuse, opioid, cocaine, amphetamine, hallucinogens, and inhalants. Inhalants is petrol sungna, Erasex. These are kids who are at 7 lakh. This is the data which is available by the All India Institute of Medical Science, which we are, again, it was the biggest study which was done in India. Coming to the worst part, death by suicide in India. This is the number by National Crimes Record Bureau, 2021. It is 1,64,033 death by suicide per year. This was during the COVID time. That means number of death into 20 times is the failure. 1,60,000 completed suicide into 20 times who attempted. It is somewhere around 32 lakhs attempted. But this is reported number. But WHO says that into 3 is the numbers which is supposed to be in the country. So if you look at 1,64,000 per year, it is almost equivalent to COVID death. We are pumped in money, huge amount of money for COVID. Look at the numbers. We are having death by suicide. And most of them are educated, who are studying well, and every institution, And recently, IIT had death by suicide. And unfortunately, we had no national suicide policy. I think 1 year back only we came up with a national suicide strategy for prevention of suicide. But again, if you look at the various other numbers, even in the paramilitary forces, the number of deaths because of the conflicts between terrorists and the other people, Maoists or Naxalites, versus death by suicide is more. That is the number which are disturbing. So moving to other issues, marital discord, family discords, we require family therapy because, as you know, the marriages are breaking very fast nowadays. Because of that, children are having problems. And COVID has started with the internet addiction or gaming addiction. That is worsening. And SLD is now picking up. Suicide prevention we need to be done. And substance prevention applications. So these are the things which we are going to talk. Now the question is, do we have so much of manpower to provide the services? Look at the number. This is again, the publication was done around 4 years back by my team. The population, we roughly take 130 crore. 10% of the population is ill, that is 13 crore. So number of beds in both private and also public, it is 60,000, that's it. Numbers required is huge number. That means we do not have bed. That has already been proved even in COVID. Number of psychiatrists, hardly 9,000. Now it may be 12,000 or 13,000. Number of psychiatric nurses, 2,000. Psychiatric psychologists, maybe somewhere around 1,000, but now it has improved by another 3 years. Now, let's improve the manpower. अगर हम लोग manpower को improve करेंगे, can it be done? Unfortunately, we add psychiatrists hardly 1,000 per year. The requirement is, if you look at the requirement per 10,001, that is the developed country, US, Canada की comparison करते हैं तो उस पे आना है. So 1 for 10,000 population means 10% means 1,000 are ill. अगर 1,000 को ट्रीट करने के लिए एक साइकेट्रिस्ट चाहिए, we require 1,40,000 है, but we are hardly 10,000. So we are adding 1,000 psychiatrists per year. Provided Indian population doesn't increase, none of the psychiatrists die, we will be able to meet this in 130 years. It's not only for psychiatrists, psychologists, social worker, this is the health numbers. And if you go by WHO standards, 3 for 1 lakh, still we require 42 years. So that's the irony, because we do not have so much of manpower. Suppose, sir, nahi sir, UG में हम पढ़ा देंगे. Next question is MBBS, BSc, mental health सभी करेंगे. We will do that. Unfortunately, there is no compulsory exam, optional 2-week internship. And even if we increase the manpower, chalo, kal we will import psychiatrists from neighboring Pakistan, Bangladesh. Like many of our doctors go to UK, Australia, we will import everybody. Still, we will not be able to fulfill the needs. The reason being is, even if we make more MDs, they will not go to the rural area. The more you study, the more you go away from the rural area. That is the irony. Jitna aap padhoge, jitna aap bade banoge, utna aap rural area se dur jaoge. The only thing which has worked in public health sector is ASHA workers. It's not improving the number of MBBS doctor. The more you provide MD psychiatry or MD surgeon, jo bhi hai, out of 100, only one who is highly motivated will go there. After 1 year, he will also get demotivated, he will come back. So, jitna aap enlightenment hoge, utna urban area jayegi. The reason is our education system is gone for rotten. Let me put it in a simple way. If you ask a MBBS doctor, ask a lawyer or an engineer, whoever is there, आप क्यों ज्वाइन किया पहले दिन? सर, मुझे रूरल एरिया में काम करना है. You ask many of you yourself only. Why did I join this? I want to do this to my rural population. 5 साल के बाद एजुकेशन दिया, गोल्ड मेडलिस्ट है. पूछो उससे, आप अब क्या करना चाहते हो? सर, बड़ा अस्पताल करना है. That means in these 5 years, you have removed his humanity, ethics, उसको एक बढ़िया entrepreneur बना के रख दिया. It's not only in health. You go to law school, where I teach in National Law School. First day you ask them, sir, justice देना है rural area की, जाके, tribal में जाके. 5 साल के बाद पूछो, corporate में काम करना है, sir. So our education system has become such a way that we remove humanity from the education and we made them amazing robots, printing machines for money. But the work which is done amazing is by ASHA workers. If you know ASHA workers, they are from the community. They are just 10th standard pass. They do amazing work. They are trusted by the community, they are by the community, and they will work for the community. And you provide a reservation seat, MBBS doctor from there, he will come here by using all reservation, he will never go back there. He will aspire for a higher, yes, it is good, he will do it. But what will happen is the question which we need to answer. But anyhow, Mental Health Care Act 2017 came, which tells that we need to improve the manpower. So for that reason, under this legislation, it is there. So we started something called as NIMHANS Digital Academy, which increases the manpower so that we can provide the care. So currently I'm heading this, and this was released. NIMHANS Digital Academy was started by the Ministry of Health and Family Welfare. So it is available on website. The number of people who have been trained in the past 3 to 4 years, the numbers are increasing very fast because of the manpower, because of the digital health. So that is basically digital. So telemedicine, which was started, which in NIMHANS was in 2007. And the community psychiatry was amalgamated with the telemedicine, telling that community or telemedicine साथ में चलना ज़रूरी है. If you ask me, P&SM should take over telemedicine, even if it is there. That means that is the way you have to amalgamate. You can't keep digital ए बाहर रखो, no. Earlier, whenever they started telemedicine in the hospital, शांत जगह दूर रखो. It will not work. Telemedicine should be next to the doctor. अगर doctor consultation दे रहा है, बगल में होना चाहिए. Then it will work. Earlier, what they did was they made a separate cabin, never worked. So it has to be next to the doctor, and it has to be run by community medicine. That's what I feel, and I believe in that. This is ECHO program. I'll not go into the detail. And NIMHANS Digital Academy started 2019. And TeleManas, which I'm going to talk to you slightly in a few moments. So now we will not go into these categories of mental health, because digital mental health, it is now how many of you are wearing iWatch or Samsung Watch? Very good. So your data has been sent to US. Are you happy with that? What is your heart rate? They know you. Your ECG, what time you're sleeping. And if you're having Android phone, where are you going? Which mall you went? Whom you spoke? What are you discussing? And if you're going to any of the social media, those same advertisement will come. Already it is happening. So, wearable devices, telemedicine, data analytics, health and wellness apps are increasing. Applied gaming, I will be telling you about that. And mental health and social media. Coming to digital phenotyping is one. You're going back fast. Digital health, social media, digital mental health record platform, patient physician portal. These are the things which are visioned in digital mental health. I will not go into the details. If you have any questions, I'll come, because it's a very heterogeneous population who I'm talking to. Now coming to the digital phenotype. What is this digital phenotype? There are 2 types of digital phenotypes. One is active and another one is passive. What is active is basically the input given by the user. आपका जो phone है, your watch है, it is taking some data without your knowledge, which you have agreed by buying the phone. And it is sending some data to the cloud. They are analyzing that. That is the passive. Active is which you have to give information. So that is digital phenotype. So are they important? Yes, they are important. What are those phenotypes? Language. Why language is important? If the person is talking negative, can we capture that? If this voice analysis is different, can we capture it? What is he posting on the website or on the social media, can we see what is he consuming? Can we monitor it? Facial expression, can we capture it? How is he movement? Whether he is actively moving, if he is moving very fast in a day for too many places, which occurs over a period of 1 week, that means he's having some psychiatric issues. No, sir, he's in the house continuously for next 1 week. That indicates he's having another mental illness. That is depression. So this has been proved in various studies. Can it be proved? Yes. Can it be done in India? Why not? How the social interactions? They have done a study in abroad. They found that who are the ladies who are pregnant, whether they will develop postpartum depression or not, based upon their social media profile, they are able to predict, yes, this lady is going to develop depression, based upon how she is interacting, what she is posting, and how many people are interacting with her. Is it she's posting, nobody is talking about her, or she doesn't get liked, there is no interaction? Yes, there is high possibility. Can it be predicted? That is the question they are answering. What is the physical activity about that person? Sleep. And if you look at any mental illness, sleep is the early thing which gets disrupted. Now, not only wearable device, now there are devices available which can be spread on the bed sheet kind. It will monitor your sleep, whether you had a quality health or not, quality sleep or not. Heart rate, variability is there. Sweat analysis regarding medication, EEG. These are digital phenotypes which are passive, which can be taken without your knowledge or even with your consent can be taken and you need not do anything. What is actively? You mood charting. Sir, savere uta, I was feeling low. दोपहर को कैसा है मेरा mood? शाम को बहुत गुस्से में था. So you go on charting the mood. You will come to know and you add it, you give the information, and by 1 month you will come to know how was your mood past 1 month. That can be told to the doctor. Diary, thought diary. What is your thought? आपका सोचने का विचार कैसा है? Whether you are taking medicine or not, medication intake, especially in the chronic diseases like diabetes, hypertension. Most of you know when you tell your dad कि dad आपको diabetes है दवा लो, तो what will be their response? Doctor हो सकता है तो अस्पताल में, घर में नहीं. So then you will tell your friend, अरे यार मेरे बाप को बोल दे दवा लेने के लिए, वो नहीं ले रहा है. So this is one of the ways bringing this app and helping them to take medication. Anger charting, substance intake, that is drugs, suicidal thought, and cognitive tasks. These are the information which can be tapped, and these need to be, these whatever phenotypes I'm telling, need to be added to the medical records. Whatever the industry is taking is not going to be helpful unless it is brought with the medical record. Not only that, nowadays there is a forensic psychiatry or forensic analysis is done by doing these various parameters. There are studies are happening, and those studies are in the domain which are not published, but anyhow, currently you need to understand these phenotypes need to be brought in along with the health records, then only you will be able to understand meaningfully how much this digital health and digital mental health will be helping. And see, whenever you talk to the patient, you will come to know only the cross-sectional analysis. If you wear a watch and it is continuously monitoring, you will get a longitudinal data which is more meaningful than a snapshot. Moving to digital mental health intervention and effectiveness, whether it is effective. So there are various ways of interventions are available. Internet way, there are people who come and say, I will treat this, we will treat that. There are many applications which have been brought, and many a time they have not been tested. Some of them are helpful. Some applications are for wellness, some for illness, some for diet, some for physical activity. And the application every year is in number of 52,000. That is the number of applications which are there, available in the app stores. What are the limitations? The limitation is 80% of the people who download an application, within 2 days, they don't use it, and it will be deleted. Similarly in health application. Unless there is engagement, unless that application is very user-friendly, very attractive, engagement will be lost. So whatever the health application is made, 80% of the time, it will not be used at all. You can do the marketing, it is not going to work. So how to decrease that? Adding the human element has come into picture. What does it mean? Now FDA, that is US-based Food and Drug Administration Act, they are now recognizing, accrediting these applications. And during that, they say this application has to be prescribed by the doctor. And there will be a person in between the doctor and the patient who may be a technology person, or it can be a patient, or another peer patient, or it may be a paraclinical person who will say, download this app. And after a few days, whether you are using it or not, is there any difficulties in this app? And he will be liaising between the application and the healthcare provider. Then the effectiveness increases significantly. That means just having a digital technology is not the answer. You need to have a person in between who is going to smoothen the interface between the digital technology and the user. Like I was in Taiwan. When I went to Taiwan and asked, sir, you are having everywhere, even in the emergency, the patients are coming, and it says, you open the slip, emergency slip, it says, your number is 10th, the doctor is seeing the 7th, you will be seen approximately after 30 minutes. Even it is emergency. The numbers are shown, there is a huge digital board. I asked, how are you able to manage? They said, sir, technology is there, but there should be a person between the technology and the user. That interface should be smoothened. If you don't have this interface, you may have an amazing technology, it will be useless technology. Similarly, even in telemedicine, you look at the US, they have amazing telemedicine, which is there since 20 years, almost 3 decades to 2 decades. They have HIPAA compliance. During COVID, they could not use telemedicine to that level the way India is used. Why? When we wrote telemedicine, since I was a part of I've done my PhD in law, I was part of this, writing the telemedicine. Niti Aayog was very clear. Why are you writing telemedicine? We gave a 110-page law telling that this should be the document. The Niti Aayog people said, "Are yaar, kiske liye likh rahe ho? Are you writing for the industry? Or are you writing for the patient?" Then I said, okay, sir, we have to write for the patient. Then have a law which will enable a patient who is in a village who can switch on and say, talk to the doctor. Don't write a legislation or a guideline which will say how the internet provider will work, how the mobile will be there. You make such a big law, and ultimately the patient will never use it. That's what has happened in US. They have come up with huge regulation, and if you miss one regulation, you will be jailed. So now here in India, they said, okay, you can use whatever smart device available. You want to use WhatsApp, use it. Doctors are very unhappy. Along with the industry is very unhappy. Arey yaar, humne app bana diya. Use karo. But Niti Aayog was telling, I want the patient who can use even WhatsApp for telemedicine purpose, let them use. Our reason for starting this digital technology, telemedicine, is to provide the care for the last person, in the last village, in the last mile. Not with the highest security, amazing security, and doctor has to undergo training to how to use telemedicine, and patient party also has to undergo training how to use telemedicine application. That's not the way. And finally, they made it simple, and that is the reason it is considered as one of the best. But anyhow, in between what has happened is many people's rosy roti has come down. That may be IT technology person who is a security says, sir, ye kya bana diya? How can a social media can be used? You ask the patient who is in the rural village, they say, sir, WhatsApp pe hum baat karte hain hamare doctor se. Why not? That is the reason we are using it here. So, but anyhow, that can be a debate for a larger thing. Now the challenges and opportunities. Of course, security and privacy is one issue. Issue is, of course, a larger, if you're going to increase the security, the people who are going to use will decrease. You come up with an application, it will be chargeable. It becomes chargeable means it will go to the patient. Patient has to pay for it. Because nobody will sell a software along. Simply they will say, sir, ये software ले लो. बाद में, sir, ये हमारा mobile phone है. Sir, ये हमारा camera है. इसके साथ और एक addition है. It goes on. And ultimately, the person who is going to pay is the patient, nobody else. Digital literacy is the biggest problem because majority of our elderly population do not know how to use smartphone. You have to help them. High dropout and poor engagements, especially in the applications. Data marketing, who owns the record, who owns the data? That is the biggest challenge. As I mentioned, many of you people are sending your data without your knowledge to Harvard, where iPhone has tied up with them, and your data is analyzed there. We don't monitor, and we trust them. The issue here is, who owns the data is the big question. Is it the patient? Is it the US? Or is it the India? Now people don't trust doctors, now the IT industry, because if the product is given free, you are the product. That is the way it has been there. So unfortunately, if you are able to come up with a law which will say, this data what is there should be used for the benefit of the public, then the public engagement increases. That is the way we need to do. Like the way Aadhaar card, when they said Aadhaar database is there, it can be hacked and it will be misused. Now they know, no, it is for the benefit of the public. The people trust Aadhaar now. So that is the way the big data has to be discussed. So there are various opportunities. As I mentioned, FDA is approving certain apps. Now India has to come up with our own approval method or believe in FDA what is done. One is Endurex is the app which is used for attention deficit hyperactivity disorder for children, for attention deficit only, not for hyperactivity. Nightwear is there. Reset-O is for drug abuse. Again, all these apps cannot be downloaded. It has to be prescribed by the doctor, and then it will be monitored by a technician who is going to see whether the patient is filling the form, sending the data or not, whether he's coming for the follow-up or not. That improves the compliance. And definitely, we require to have a professional tagging. What does it mean? The doctor writes the prescription here. We want to know who is the doctor, whether he's a doctor or somebody else is writing the prescription. Because the issue comes is, the patient can generate 10 prescription from 10 doctor by sitting at his home. Unless we are able to have a tagging for the doctor and the health record, that is ABA, which has been discussed in the previous session. So if you are able to do that, then we'll be able to, and in a matter of maybe another 8 to 10 years down the line, what we are talking about, Aadhaar card, there will be ABA card. Every person will have ABA card. If you give permission with your OTP, then only your health record will be seen, otherwise it will not be seen. And certain sensitive records can be come up with a double security measures. Maybe MTP, it will be under double security measures, or it may be even a mental health treatment, maybe double security measures can be brought in, or if you say, I don't want this to be recorded in the data, that can be removed, or it will be kept in a confidential unless there is a law agency gives a permission. That is the reason PDP bill, that is Personal Data Protection Bill, has been in discussion for a long time. It was withdrawn. Now it is introducing. And definitely the day will come where we will be talking about this. In next 10 years, you will have, my ABA card is this. You meet with an accident, if you know that, okay, he is the person so-and-so, where he is there. And an amazing thing has happened even in Karnataka. They were wandering mentally ill, they were found, and they were admitted in a various rehabilitation center. Then they decided one day we will go and make their Aadhaar card. When they went and tried to do the Aadhaar card, they realized they had already Aadhaar card, their family address came back. So we were able to send them back to their family. So those are the benefits of these digital technology. So the novel initiative, the last one I'll be talking about is these are the various initiatives which are occurred in the India in the COVID, that is e-Manas, Telemanas. There are various things are there. But anyhow, you can go through all of them. They are available online. But if you ask me, the n number of amazing things have happened in the COVID. But of course, it needs continuous sustenance. But unfortunately, after the COVID, some of the apps have killed. They have been moved out of the market. And some of them are very good initiatives have occurred. Some of them occurred even from Pune. That is the, I think Your Dost is the one which has been started from the, so the last one, this is, I will not talk about this. And to say finally about the Telemanas is the one which I said in 2000, 1 year back on October 20th, a telemanas was started. This is by the Ministry of Health and Family Welfare on October 10th. Don't go by this slide. We have completed, this is a telemanas, is a free helpline is available. You can type it on Google, you'll get that. The first call goes to the counselor who will take the call, and then they will ask what is happening, and they will talk to you, and they find, no, there is definitely a mental health issue is there. It will be escalated to a mental health professional who will take the call, and if they feel that there is a requirement, they will do a video consultation. And if that doesn't help, home visit will be done, or the patient will be called to the nearest district mental health program. So just 3 days back, 1 lakh calls have been completed across India. It is a telemanas, is a national tele-mental health initiative by the government of India, and it is a comprehensive mental health services. The training has been completed in Srinagar, has been completed in Chennai, Jharkhand, and our team is visiting, I think, the Chhattisgarh also for the training program. Already online has been done, in-person training of these counselor is done, and this is one of the flagship program. If it is going to take off and it is left to the state to take it up completely or to leave it so that the telemanas can become a national program, because it is going to amalgamate with the National Mental Health Program, which is there already, DMHP, and the telemanas adding digital to this. So both will amalgamate and a comprehensive mental health program will be done. It is not only in the mental health, it will be done for even for the other national programs slowly. But again, the initiative has to be taken from the champions, people who are youngsters like you, and take it to the larger picture. Thank you very much for giving your valuable time.
Thank you for a wonderful session, sir. Your insights on mental health in this digital age were invaluable and greatly appreciated. It sure has expanded our understanding and equipped us with practical knowledge for promoting digital mental health and bringing together mental health professionals and patients in this digital age.
I would now request Dr. Samita Jadhav, Director, Symbiosis Institute of Health Sciences, Symbiosis International University, to felicitate Dr. Suresh Bada.